when you read the objectives of the PHN program, you'll have an appreciation of sort of the nature of the environment that we're trying to navigate. Why do I say that? Because we're actually contracted to increase the efficiency and effectiveness of medical services, particularly for patients, aka people, at risk of poor health outcomes, and to improve the coordination of care for those people so it's right place, right time. Might be the next slide. There it is. And I say, for those of you who think about the conundrums that you face in working with us, that it's that, is it? Okay, got it. Thank you. You know, we get a lot of push around social determinants and a lot of push around trying to enable people to access care, to prepare them to access care. Strictly speaking, this is what we're funded to do. And so I just say that for those of you who appreciate the dilemmas associated with social determinants, and particularly in our more remote communities, notwithstanding we've got areas in Perth where the social determinants are absolutely key to a person's health status. And the other thing in looking at this is it's a contested space, and PHNs are often seen as the answer to everything. Well, in fact, we're not. And I'll explain that a little further, because many of you would say we've got a really good idea to do a really great thing in X, but it may be outside our framework, and we're always trying to navigate that well and appropriately to get good care for people, but we've got to be careful. So I won't read the slide, you can read what else we do. This slide really just gives you a bit of a overview, and look, we can put these slides up in Primary Health Exchange, so don't feel like you've got to write down the notes, but it gives you a sense what is the expenditure across WA through WAPHA. And this gives, going to Anne's point, we've had a little bit of growth in the last few years, which is added to both the sort of turbulence from my perspective in what we commission and how we commission. And also we've had a maturing of the program whereby something that was out of scope in 2015, I'm just going to say this, psychosocial support, absolutely out of scope, now it's in scope. So for you, if you get confused, go your hardest, because I get it. Because we are incrementally just developing new things that come from the Commonwealth for us to commission. So I just say that. So if you go, I don't know what they do because they couldn't do this and now they can, it's because of the nature of the changing brief. This is how our expenditure from the Commonwealth is broken up. I think the only note I'd make is don't be sort of excited by the 52% of mental health and suicide prevention, because probably more than half of that is programmatic funds and not flexible. So I'll just say this. For Rupert, Headspace is one of those, and we don't treat Headspace as a flexible model of mental health access to care. So I just say that. So it's not all flexible and can be used in innovative ways. There are programs inside that, not unlike the Aboriginal Health Integrated Team Care. That's a program, and there are providers in this room, and it's very clear and very specified what can be purchased and how that's delivered. Jonathan. So to be fair, you can see there's a mix here of flexibility and quite tight, rigorous programs. So this was the election, albeit, and I didn't drink a lot on Saturday night, I have to say. I got up and I rode on Sunday morning, so, you know, all good. But what we can say, and this is really early days for us, because, you know, there's not a lot of communication going on yet with the Commonwealth. I think they're a bit distracted with a few other things. I think for David Axworthy, there's a commitment in there that we understand will be administered by the PHN, which is the $14 million walk-in adult community health centre. We don't know what that means. I just thought I'd say that straight up front, but we understand that that's going to occur. But the pale blue box above we have a much clearer understanding of those developments. Why are these listed here? Some of these are, for example, for those who work with general practice in the room, some of these developments are developments for general practice, but we will work with general practices around those developments. So, for example, the notion of chronic disease funding for people over 70. So I say that even though it might not look like it's ours, it will require us to start working with general practice in certain ways. Oh, sorry about that. Keeping this all in perspective, see that little red slice? That's us. And that's the other thing to remember. We're a little tiny piece of the jigsaw. The important piece of that, though, to be reminded is, and I'll just build on what Anne said, that was the reason that our wonderful Chris Kane actually lived in Royal Street for virtually half a week for 12 months, to ensure that primary care was absolutely captured inside the Sustainable Health Review. So that notion of joining up the system was evident, and you'll see that, have seen that in the recommendations. And while we're not an advocacy lobbying organisation, clearly when you look at the little red slice, it means we have to work tightly with others to help improve the system, and wherever possible take leadership around the primacy of primary care, but also the joining up of social and primary care together. But we can't, while we have done many submissions to royal commissions and other things, and we put the position, we are not, from the Commonwealth's perspective, meant to lobby on anything. I just say it a little bit like that. But that is helpful to be reminded. So I'm looking at that and thinking out loud. So sorry, I'll just move on. So what is this? This is a commissioning cycle. And I think one of the changes we're trying to create, and I say that, and hence the piece of work we've done on commissioning for better health. Commissioning is not just giving out a block grant for a thing somewhere. It actually sits inside this circle. And while we haven't yet got that going as well as we would like, you can sort of see this notion of the needs assessment, getting much better detail on what is required in a community, how is it that people access care, what are the outcomes of that care, is actually pivotal to the process. And so we can't take one bit out and treat it on its own. I mean, to be fair, I was in Broome earlier this week, and the needs assessment that pulls out Broome, my bit saying that, is not bad, but it needs to be contextualised to the Kimberley. The clinicians, the providers, the community will know more about the Kimberley than we could ever say. So our needs assessments really require good insight and input from key stakeholders to give it life, to then really know what we need to be doing next, not just crude black and I don't mean this because our team did a fantastic job, but there's only so much you can draw out from the data. Monitoring and evaluation, we've got a fair way to go, and those of you who are providers know the sort of pain of having a contract from us and what you report on, but part of this process is to actually streamline that and use that data that you provide to us well. This commissioning framework's not up for negotiation with the Commonwealth. It's absolutely core to what we have to do and what we have to report on. So, commissioning for better health. So, last year, we needed to do a review of our commissioning framework. We were required to do that, and rather than just do a tabletop exercise, we thought we'd go down a bit more of a serious path here and actually do a review of how we do commissioning. So that describes what we did. And earlier this year, April, we launched the report. There is a hard copy on the table, but you can download a copy off the web. And if you want to sit back, chill out and read it, go your hardest. But what it does include is what we've heard from you, but also what we're going to do next and the time frame for that, and how we're going to engage you in that. So this is just a very light summary of what we heard from you. And on one hand, I wouldn't have thought this is a surprise in any of this. And to be fair, some of this commentary in here also relates to the state's work on the supporting communities work. We're knocking on the door to be engaged in that, so we can try to align what we're doing with what the state's doing, contracting, procurement and so forth. We know also, and I think this was said there, we've got some missing pieces of the jigsaw, which is these enablers of workforce planning, digital health and so forth. Importantly, these are the things this is the work plan for the next, sorry, I'm just looking at the time, over the next number of months. So we're establishing a governance committee, and there's representative membership of that, and that is actually to help provide us advice as well as ensure transparency around the process as we go forward. We're going to, and you'd think we would do this, but to be, honest, it's been very tricky. Take a program management approach so that there's not mixed messages across our system, not duplication of effort and so forth, so that, where's Mel? There's Mel. We've got a little expertise sitting in Mel around alcohol and other drugs, but we've got to make sure we've got that leading that, this is not about you, Mel, in the organisation, so the provider sector, the key stakeholders know where the touch point is in the organisation. One of the important pieces of this work is the resource allocation formula, which has taken some work. You'd be surprised to know that the Commonwealth wouldn't share theirs with us, so we thought we better develop our own. And we've done this to ensure that funds go to those communities where it can be absolutely demonstrated there is a high need. So I'm just going to use Headspace because Rupert's sitting there, but we have Headspace services located in communities where there is no psychologist at all. So how do you complement the skill set you need in a Headspace service if there is actually no workforce? So there's some nuancing in there for us that's around ensuring that we ensure our resources are allocated to build that capability where it's required. Excuse me. And you can see the rest of the sort of key pieces of work that are going to occur over the next months. Now, some of you might sit there and say, well, why haven't you done it already? You're 4 years old. And I'd go, you're right, we could have. However, we used to use a phrase in our place that was about building a plane and flying it simultaneously. We've probably dropped that phrase, although some days it could feel like that. But with that volume of activity and the pressure of commissioning services, notwithstanding what we're doing with general practice, meant some of this work now is timely for us to do, rather than we didn't want to do it at all. We would absolutely and honestly say, while we communicate a lot, we actually don't communicate like this, nor do we bring the sector together in a way that we can have more meaningful conversations around life in the universe. So it's something for us to make sure that wherever possible, we might over-communicate in some ways, but make sure we're getting the right dialogues happening. This is about both not only strengthening us internally, but more importantly, the experience you have of commissioning with us is much clearer. I won't say another thing other than this is a significant piece of work, and we are working on the premise that over the next 3 years, as these processes and strategies get in better, the level of connectivity between all of our strategies will come together.